Thankful to AIOS for accepting our instruction course today. This is an early morning session, and we are hopeful that at the end of the session, we would be well informed about various topics which would be covered. And this session would truly be fruitful for you all, being this early morning session, and all of you have taken out time to attend this session. So we have got a keynote address also of Dr. Mohammad Saad in this session, who would be taking the future of fungal keratitis. As soon as he joins, we would take his talk. Regarding this session, that is comprehensive management of corneal emergencies, the diagnostic dilemma and treatment challenges. We have got some renowned corneal specialists in this instruction course. We have got Professor Radhika Tandon, Professor Titial, Dr. Fogla, Dr. Amit Gupta, Dr. Banati, and myself. And I would request Professor Radhika Tandon, Madam, to take her lecture on contact lens associated corneal emergencies. This is a very important topic, and we all come across various complications associated with contact lens usage, which are to be treated optimally and timely to prevent any further complications and for visual rehabilitation if there is any complication in such cases. So I invite Professor Radhika Tandon to start this session.
Thank you so much. Good morning, everyone. I'm very grateful to Professor Bhavana and AIOC for giving me the opportunity to present in this session. I'm going to cover contact lens associated ocular emergencies and complications. Basically, when you look at the contact lens evidence-based academic report of 2021, though contact lenses were invented as long ago as 1887, over the years there's been a revolutionary change in the type of material and the usage of contact lenses. And when we're looking from the optometrist or the practitioner's point of view, it's very important that when you're dealing with a contact lens practice, you must engage the people who are dispensing the lenses, because as ophthalmologists, we're totally very well equipped. But contact lenses is something which, even in the previous session, the speakers had mentioned, many people take it very lightly. They take it like a cosmetic product, and often non-professionals are handling the dispensing and the patients are not being properly educated. So one has to simplify this knowledge, and you have to sort of empower the patient to know about what to expect when they start wearing contact lenses. So basically, one could look at the location, the etiology, and the severity of whatever the problems are. And when you look at contact lens associated ocular emergencies, they may not look that terrible as compared to the really true emergencies that we see in ophthalmology. But here I want to specify that with a contact lens, when a person is out in the periphery or out in the public and is not under proper care, then the emergency has a different context. Like even the presence of an epithelial defect or a small dryness and a weak spot in the epithelium, that can lead to devastating effects. And generally, a large number of patients actually do have a red or painful eye requiring emergency eye care, which is quite a lot when you consider the total number of contact lens wearers. And what would you take as a red flag for a situation which may escalate into a true emergency is a reduction in wear time, discontinuation from wear, need to seek emergency eye care. Similarly, we do know that there are well-defined anatomical and physiological effects on the ocular surface as a result of contact lenses. And young people with refractive errors who are wearing contact lenses earlier, when refractive surgery was more complicated, often contact lenses would be a go-to option. But now refractive surgery having become so safe, often the contact lens wear is more dangerous in certain situations if the patient is not going to be careful. Because even 43% of asymptomatic wearers were actually found on review to have clinically observed ocular surface signs. And you can imagine what would be the devastating effect if a young person develops a central keratitis. So the components responsible for complications, they are of course physical and physiological factors. They could be wearer related, because often patients may sleep with the contact lens, they may not be that careful with the hygiene. And this is another thing you need to take into account when you're counseling a patient whether to wear a contact lens or not. And then there are some patients who actually require the contact lens actually for their vision, where they don't have any other options, such as keratoconus or pellucid marginal degeneration, which are not amenable to surgery. And then there are, of course, pathological factors. So the checkpoints, one would like to look at the compliance and compatibility. And if a patient comes with an emergency, you have one point of time then to look into what are the weaknesses in the use of the lenses, the material design, etc. And you can take corrective measures at that point. The most dreaded complication, of course, is microbial keratitis. You can also have sterile keratitis. There can be metabolic effects and mechanical effects. And you can also have toxic and allergic disorders. Sometimes patients will not understand the instructions. There was a lady who came recently who was putting the contact lens solution inside the soft contact lens and then putting the contact lens onto her eye because she felt her eye was dry and maybe that would help. So there could be tear resurfacing disorders, dry eye, and contact lens discomfort. Now, contact lens related complications, there is a review of a whole lot, but as we know, bacterial acanthamoeba and fungal keratitis are the most severe, and as ophthalmologists, we all know how to treat them. If I have a patient with contact lens induced keratitis, I would definitely scrape the ulcer and also send the contact lens, the solution, and the case for culture, even if it doesn't help to know what is the actual organism, but to get an idea about the hygiene. As often the patients, of course, have thrown away the contact lens, but you can send a specimen from the case as well as the solution and the tip of the bottle, which is the dispensing the solution. We can have corneal staining and corneal edema, which may not look like an emergency from a sort of true emergency point of view, but for a contact lens wearer, it is actually an emergency, and for the practitioner who detects it, because if you don't take care of the problem at that time, you may end up with a more devastating problem. So here are a few case studies. This is a patient who's been wearing RGP contact lenses for keratoconus for more than 5 years, and it was a flat-fitting lens with apical staining marks. There was discomfort and unstable vision. So observation on removing the lens showed that there were ring marks, there was poor tear exchange, and there was staining because of lens touch. So poor fit, this can lead to corneal edema, corneal staining, and this can then lead to an escalation or a cascading effect of a keratitis. So it's very important to examine the patient carefully, and also it's important to make the patient wear the lens and reassess after half an hour or 45 minutes to see what is the effect before you send the patient home. You can have staining on the cornea post-contact lens removal. So this is again something which needs to be taken care of. And as you can understand, for a patient with keratoconus who is really dependent on that lens for vision, so just removing that contact lens and saying you have to manage with spectacles is like a complete change in what they can do and how they can live their life for the next day or two. So this is very important to intervene early. There can be contact lens deposits. There could be poor care and regimen. And progressive keratoconus, this is another example of a patient who was prescribed the Rose K2 lens, and you can see there are staining ring marks and lens impression on the cornea post-contact lens removal. And then after fitting again, one should reevaluate after 60 minutes and then remove the lens again. Only then will you see these contact lens compression rings, which will indicate that actually the fit is not perfect. This is an example of a post-C3R patient fitted with scleral lenses. Even with scleral lenses, always look carefully when they come in wearing the lens to look at the tear film debris or the lake which is present to make sure that there are no debris or there is no trapment. Altered tear film after using a convention soft contact lens for long hours can also be there. Generally, it's very important to caution the patient, but many times the patient will be wearing the contact lens for 10 to 12 hours and sometimes even sleep with the contact lens, which is definitely a dangerous problem. Regarding complications of scleral lenses, now this is very daunting and it's very difficult for the patient to learn how to wear the lenses, and it requires a lot of chair time. You can have application bubble, difficulty with lens removal, non-wetting, surface deposits, corneal bogging, scarring, inflammation, and solution sensitivities. And of course, there are fitting challenges. You must see if there is any nipping of the vessels at the end, which are showing that there are tight edges, and there's an impression ring after removing the contact lens. So when you fit it, let the patient wait for half an hour, 45 minutes, or an hour, and then reassess afterwards. There could be apical bearing, there could be impingement and blanching of the vessels in the periphery, indicating that it is too tight. It could be sagging as well, and there could be conjunctival or limbal redness as a result of the poor fit. There could be a stuck scleral lens, which can be quite a sort of very panicky situation for the patient. There could be reduced tear vault. There could be deposits over the contact lens surface. There could be also solution toxicity, and the patient can come with a very red eye. There could be hypoxia with neovascularization, and this is an example of a 30-year-old female with pellucid marginal degeneration wearing a large diameter scleral contact lens for 10 months. She complained of stinging after lens removal, photophobia, frequent blurring of vision, and slight discomfort post-lens removal. On a detailed ocular surface examination, it was found that she had a poor tear film, she had a high OSDI score, and the wear time was approximately 17 to 18 hours, which tends to happen in these patients because they're totally dependent upon that contact lens for their vision and daily care. On slit lamp examination, you could see inferior steepening. There could be well-fitted scleral contact lens on an irregular cornea. There could be irregularity of the tear film, scratches on the lens surface. And these lenses being expensive, often the patients are not able to, they try to avoid having to change them. Thick layer of deposits can be there, and staining of the contact lens post-removal. So the treatment, patient was advised to stop the scleral lens for a week. So it's very important to have a rehabilitative pair of spectacles as an alternative, and then you would prescribe lubricants and review after 3 to 4 weeks. Post-treatment follow-up, there was a remarkable improvement, and the patient was going to go back, and you require to give them a lot of psychological support because they get quite devastated with the concept that now they cannot use their contact lenses and will not be able to, say, go to work or do whatever their daily routine is. Deposits and care, you can see patients of severe keratoconus, how they do well with a well-fitted contact lens, but you can have lipid deposits, so that they do require periodic professional cleaning. We can have a protruding close, poor stability, refitting can be done, and you can also advise reusable moist heat masks with complete usage instructions, and one can sometimes give antibiotic eye drops for 10 days, and sometimes steroids may be required as well. So in this, to control the inflammation, because we have shown that just having the contact lens on the surface is, after all, a foreign body, and it does produce changes in the meibomian glands. That's another total different discussion, and we have a paper on that. But this is indicated to always be aware that even contact lens wearers do have MGD, and they do have an ocular surface instability, and they can be complaining of stinging or sensations, and often they do not, they're not very particular about being regular with their lubricant eye drops. So a well-fitted scleral lens, look at the edge, and OCT is a very good tool to assist you with the process. We have a patient of post-RK ectasia who came for the first follow-up prescription. There was conjunctival blanching due to tight contact lens edges and indentation, and the scleral bowl was not properly fitted with saline. After all this was addressed, the patient was comfortable and was able to continue with normal life. So the tips to care: regular follow-up, early presentation, avoidance of overnight wear, reminder cues to the patient, and so consider changing materials, modalities, care, and system according to the patient's need. Thank you for your attention. Okay.
Thank you, ma'am, for a very informative talk on various emergencies associated with contact lens usage. We have got Professor Tityal sir amongst us to take the lecture on corneal emergencies after refractive surgery.
Yes, come. Thank you. Good morning, friends, and I'd like to thank Professor Bhavana for getting us into this very, very exciting and important instruction course on corneal emergencies. We do have many, many scenarios where cornea can get injured, and one of the major surgeries which we do in the cornea nowadays are refractive surgery in a healthy cornea. And any complication there can be significantly damaging to a patient's vision as well as the confidence of a patient also, because this is a surgery which is being done on normal eyes also. And we do have scenarios which can be managed very effectively without any significant reduction or damage to vision of patients. Unfortunately, these complications are quite rare. though these surgeries are so common across the country and across the world also. Going to highlight some of the important complications which we may have in these scenarios. No financial disclosure on my side. If you look into a corneal emergency post-refractive surgery on a cornea, you can divide into two major categories. In the past, we used to have a lot of incisional surgeries. Those are radial keratotomies, and you can have incision rupture, acute hydrops, microbial keratitis in those cases. As far as corneal ablative procedures are concerned, you can have flap making surgeries. You can have flap related complications, stria, dislocation, keratitis, epithelial ingrowth, DLK, and other important complications which may happen in these cases. So these complications may be seen in a LASIK patient where you make a flap, or these are also seen with a smile procedure also. So let me take you through a few complications which may have emergencies, especially radial keratotomies, because we still see a lot of patients because we have millions of patients who have undergone radial keratotomy in past. And if you don't manage them in appropriate time, you can lose the vision. In fact, you can lose the globe also in these cases. So this is one patient, at 19 years ago, he had radial keratotomy done. He had a minor injury and all 6 incisions opened up. So these incisions are very, very weak. They extend from a center to periphery. They are at a depth of 80 to 90%. And with the minor injuries, they can open up. And that can totally create the scar, which will totally take away the vision of a patient also. Now, this is a patient, this is after a few months of a repair. And subsequently, you can see the scar is also going up to the depth. In such cases, you may require, despite having a vision of 660 in this particular eye, patient is not actually seeing well. So these patients may require a subsequent keratoplasty to rehabilitate these patients also. There's a few other complications which we have seen, infection happening post-rupture in the scar, or you can see peripheral scar with little bit of hydrops happening in these patients with ectasia, and the vision is absolutely lost in these patients. So this is one of our reports where we had the post-RK acute hydrops happening in these patients. And you can see a risk factor is vigorous eye rubbing and trauma to the eyes. Sometimes you have an ectasia happening in these patients, and that also may compound these patients to undergo hydrops also. This is one of our patients had a hydrops also. Subsequently had an infection in that over the hydrops area. And this patient was managed subsequently with antimicrobial treatment and injection of air intracamerally to rehabilitate these patients. So we do still see RK patients. Always make sure you examine them properly. Look for any dry eye conditions which may predispose further complications in these patients happening. The secondary procedure which you do in these patients should be very meticulously done. It may be a refractive procedure, it may be a cataract surgery, so you have to be very, very careful, not let this incision open up during your surgery. Post-LASIK, mainly it is a flap-related complications, which may be a flap dislocation or a simple flap stria. You can have minor stria to flap dislocation. Then you have various interface-related problems. Mainly in long term, you can have epithelial ingrowth. A major problem which we face is the infection in these patients, and that can be devastating sometimes. Like this is a patient who had a peripheral infection. This is a patient with DLK type of picture, and this is a patient with a minor stria, and this is a huge infection happening after the epilepsy procedure also. What are the risk factors for having a stria in these patients? You can have a minor trauma, or patient may not realize that surgery has been done in the evening and rub the eyes. Sometimes on the table as such, if you don't examine these patients after your procedure, may have a minor folds, and that may become stronger subsequently. It all depends how significant are these flaps in terms of visual outcome wise. If patient vision is good, you may not have to do anything. But if vision is decreased, then you may have to tackle. So this is one of our patient came within the first day of a surgery, and you could see the folds. So this is a minor trauma. And normally these folds are radiating from the hinge area to periphery. And these cases have to be managed immediately, because even after one day of surgery, you still have to do a epithelial debridement. So don't take this is one day only and you can just do a massaging of a flap, which is not going to work out. So you have to always remove the epithelium, especially in a long-standing folds maybe after 48 hours to 1 week or 2 weeks. You have to do a complete epithelial debridement before lifting the flap. After you lift in the flap, then you can do a massage or iron out the entire flaps. Because this patient came within a first day of surgery, I could iron out without lifting the flap. If you have a patient coming after 48 hours, 72 hours, then you'll have to lift the flap, hydrate the flap, massage from both superior side of the flap and inner side of flap, and make sure the flap is absolutely well oriented. You may put sometimes a mark in the peripheral area so that your position is absolutely correct in these patients. This is end of surgery. You can see very nicely we have polished, and you can see under retroillumination, things are clear. Always take these patients in a major OT. Make sure you dilate the eye so they can see the folds very effectively. If you don't dilate, you don't see the folds effectively, and you may not do a correct job for your patient. So this is another patient had a trauma and had a dislocation and a small epithelial defect. Patient came out after some time. Make sure you do a complete investigation on your patients. Otherwise, you might miss out because these are patients going to come for a visual improvement. So you have to have an absolute good recording, right from a topography to anterior OCT has to be done for these patients. So this patient, we lifted the flap, removed the epithelial ingrowth, put mitomycin C, and this is after 1 month patient improved significantly. So this patient came during the post-COVID time, had an injury a year back, where the entire flap got totally disorganized and large epithelial defect in growth happening. This patient vision dropped down to 6/60, huge epithelial hypertrophy and a flap getting to one side, which caused significant epithelial ingrowth, and we had to ultimately take off this flap because this flap was not really giving a visual improvement for patient. You can see a large epithelial ingrowth, flap totally dislocated to one side. I could nudge out the flap edge after removing the epithelium, took out the flap with the flap lifter, and subsequently remove the entire flap. So this is an amputation of flap which may be required in some patients where you feel the flap may not be effective enough to completely surface the stromal defect, as well as it's not going to give you a good visual outcome in these patients. Better to take off and the outcome may be better. We applied mitomycin C in this patient. Subsequently, surprisingly, this patient had a 6/9 part vision without the flap. And at 1 year later, had this is pre-op topography and this is a post-op topography. Patient improved to 6/6 subsequently. So this flap normally doesn't really contribute to a refractive device as far as post-LASIK flap dislocation are concerned, and you can still take out. You can read this publication in IGO subsequently. So you can say ingrowths are rare, but they do see sometimes they're in the peripheral areas. You have to just observe them. If they come to central area, then you may have to take off. Like this is the case, large epithelial defect, which may require a removal subsequently. And if you have IOCT, you can do IOCT guided removal, lift the flap, partial lifting can be done, take out this epithelial ingrowth, use mitomycin C, and subsequently keep the flap back and maintain the integrity in these patients. This is after day 1, after 1 month, 1 year, patient did very well subsequently also. This is a technique described in IGO. You can read this entire technique of how to tackle the epithelial ingrowth in these patients with the algorithms of management of various types of epithelial ingrowth. This is one rare patient of mine, small epithelial ingrowth in a post-smile patient. So these are patients where you have to do early, intervention so that it doesn't go to pupillary axis. Again, here you can open the side cut again and take out the entire area. First, I'll make a pocket here, then use a reverse Sinskey hook as you use for our DSEC surgeries, and take out the entire growth, pull it out, and it comes out very effectively. And post-op period is uneventful in these patients. Don't wait for this epithelial ingrowth to enlarge subsequently. We all know microval keratitis can happen in all procedures related to cornea, more so in a refractive surgery. It can be surface ablation, LASIK, SMILE, and we all know Mycobacterium is the one which is the most important infective organism to cause keratitis. Absolutely, there may be various risk factors, but one of the most important is the reuse of microkeratoderm. Luckily now microkeratoderm use is so less that things have got manageable in these cases. Always make sure you intervene effectively, early, diagnose early, otherwise management can be very, very tough in these cases. These are varied presentation of post-LASIK infection, maybe just in the flap, interface, happy pion, so you can have so many other presentations these patients happening. Early recognition, early management, if needed, flap lifting, needed flap amputation, scrape and do a absolute good microbiological examination. Don't delay up to this stage where you can't do anything. You have to do a therapeutic keratoplasty. Their outcome can be absolutely not desirable as far as patients concerned. These are one of our patients where we had a presentation, a small, keratitis interface. It went to a flap melt, ultimately required a deep line keratoplasty. Sometimes doing a DALK in these patients is as advisable. You can see this is the patient with fungal infection. We did a DALK and patient did well for a 1 month. Subsequently, recurrence happening. Ultimately, we have to do the therapeutic graft also. To make sure your interface is effective, make sure remove that. If the stroma is involved, then you may have to do a therapeutic keratoplasty in these patients. One thing here to highlight, sometimes you have an infection or a DLK, which may be confusing. But if you see this is a DLK presentation, you can have a very, very translucent, small dot-like opacities in the just inside the flap only. It doesn't extend beyond the flap, and minimal AC reaction and corneal reaction as compared to infection, where you have a very significant inflammation happening in these patients also. So you have a large range of infection happening, which may be bacterial to fungal to mycobacterium in a post-refractive surgery patient. One thing we should learn is always be suspected to infective etiology in your patients and manage them appropriately. If needed, you should start the anti-infective for a longer period in your patient, especially compromised patients with the significant dry eye, patients with the contact lens use, lid deformities or lid infections in these patients. This is one of our case where it had a pressure-induced stromal keratitis. Typical presentation of having a good vision for a 2-3 weeks and suddenly vision going down with sensitivity to light, photophobia. If you see, the pressure may not be appreciable because there's an edema in these cases. You may have a falsely low pressure. But if you do antisegnosity, you can see a clear space between flap and the stroma, which is a fluid interface happening in these patients. Increase the steroid, and give an anti, decrease the pressure, and this entire thing goes off within a few days and patient vision improves. So always suspect high intraocular pressure in these myopic patients because some of them may be a steroid responders and they can present like this. So you have a large gamut of problems. Post-refractive surgery, as I said, they are very, very rare, but once it happens, you have to manage them very effectively as early as possible so that effective damage doesn't happen with these associated corneal problems. Most dreaded will be infectious keratitis in these patients, and any complication which can be managed should be managed appropriately, not only physically in the eye, but psychologically to patient also. Thank you for your kind listening.
Thank you, sir, for a very informative lecture here. You gave the overview of all the corneal emergencies which can come across in the post-refractive surgery period. I would just like to add here that should you come across such emergency and the patient, there is a diagnostic dilemma or the patient does not respond to an instated treatment, do not hesitate or rather refer the patient. It is always a good option to refer the patient to the operating surgeon or to the cornea specialist for an optimum management of such cases. Thank you, sir.
So with that, we come to the next talk. Professor Bhavana Sharma is going to talk about closing the corneal perforation. Professor Bhavana is HOD Ophthalmology in AIIMS Bhopal, and we are very appreciative of this instruction course, which is covering such important aspects of corneal emergencies.
Thank you, ma'am. Thank you, ma'am. I would be talking on the corneal perforation and its management, various options available with us for closure of these perforations, and they are truly the devastating complication and cause significant morbidity in terms of both structural and visual deprivation, and hence it is required that we do an appropriate timely management of such cases. So I would take you through the simple temporizing measure of corneal gluing or the glue BCL to the more permanent measures of corneal transplantation in this lecture, in this presentation. The causes of corneal perforation can be both traumatic and non-traumatic. What we come across generally is the infectious causes, and because of various autoimmune disorders, peripheral ulcerative keratitis and Moran's ulcer. So the management of such cases would depend on the site, the size, and the underlying etiology. Depending on the size of the perforation, the small perforations can be managed easily with medical management and the bandage contact lenses. Larger size perforation, that moderate size perforations may require gluing, the amniotic membrane transplantation, Tennant's patch grafting, or conjunctival hooding or amniotic membrane transplant, depending on the etiology of the patient, etiology and the site of the lesion. Larger lesions, that is more than 5 millimeter, may require keratoplasty that can range from therapeutic penetrating to lamellar keratoplasty. Taking first the tissue adhesives, they are the simple procedures and they can be very versatile procedure. They can be optimally utilized for patients of small perforations less than 2 millimeter. Two types, that is, we can use either the non-biologic or an alternative, that is cyanoacrylate, or the biologic, that is the fibrin glue. In this video, I would show you that it is important first, as the first step, that you debride the surface with all the debris, the exudate and the devitalized tissue from the surface. Make the corneal surface sufficiently dried with the Merocel sponge, followed by, yes, so you can see this corneal perforation here. The drying of the surface is very important so that the adhesive is approximated into the site appropriately, followed by application of the glue. Here I am using the cyanoacrylate glue to close this perforation. It is important that you put an adequate amount of glue, not exceeding, and it should not be very less also. If it is less, then it may result in continuous leakage from that site. If it is larger size, then it may form a bolus application and it would be very uncomfortable in a non-uniform surface. There's an alternative technique also where we can use a sterile plastic, a small disc made out of a sterile plastic drape, and through which we can apply the glue into that site. Again, it is important to debride the surface of all exudates and the devitalized tissue. Make the area dry, measure the size of the perforation, and the disc made out from the plastic drape is used to apply the glue over that surface. It gives a very uniform coverage of the glue to the surface, and the margins are uniform, followed by the application of the BCL. Excess of the glue is also to be important to be removed from the sites, and followed by the application of the glue, followed by the application of the BCL. These are some of the pictures of our patients who did very well after application of glue. This procedure buys you time for any definitive procedure or an elective keratoplasty in a non-inflamed eye. Coming on to the amniotic membrane transplant, it is again a very good procedure, by the way, that through the, because this is a non-inflammatory tissue and it incites minimum of vascularization. So it is important that for central lesions or for lesions which are around moderate sized perforations about 2 millimeter can be very adequately managed by amniotic membrane transplant. And this video is courtesy Professor Radhika Tandon. Here the multi-layered amniotic membrane transplant is used for closing the defect. You can size the amniotic membrane as per the incompatible to the corneal perforation. With the help of the fibrin glue, the different pieces are used to close that, used to cover that defect. And the fibrin glue keeps the membranes into place, and followed by an overlay amniotic membrane, which is again secured with the help of 80 Vicryl in place, and followed by the bandage contact lens. So this is one patient which we did, there was a PUK in this case, and he landed up into superimposed infection. And first we managed this case with the BCL, with the glue BCL, followed by amniotic membrane transplant. And this patient did very well with the formed anterior chamber at the end of the procedure. Now we would be doing an elective transplant in this patient. Going on to the third procedure, that is the Tennant's patch graft. So this is, the importance of this procedure is that it is an autologous tissue, and we harvest it from the patient's eye, and it provides the fibroblast, being a connective tissue element. It provides the fibroblast into the host corneal tissue, and very nicely it covers the defect, which provides trophic substances as well as the mechanical support to the corneal perforation. So this is a small video of Tenon's patch graft which is being done for this impending perforation of about 3 millimeter in this patient. So the tissue is harvested, the Tenon's is harvested preferably from 2 millimeter away from the limbus in the superotemporal or the superonasal quadrant. It is good to measure the size of the perforation, and the Tenon's patch should be slightly oversized in comparison to the perforation. Followed by, once we have seen that, we spread it over the tissue, we spread it over the cornea to know the adequacy of the size. We create side pockets into the perforation and be very gentle in doing this maneuver so that you don't cause any more damage to the underlying very thin bed or to already perforated area. So these side pockets are created, and we put the Tenon's patch graft over this side and tuck in the margins of the Tenon's patch graft into the surrounding side pockets which we have created. With the help of the fibrin glue, this Tenon's patch graft remains well in place. After we had tucked in the complete tissue into the surrounding of the perforated area, we put the overlay suture, that is the mattress overlay suture, over to keep the Tenon's patch graft into place in the post-operative period also. So this is how we secured the Tenon's plast into the perforation and close the defect. This is the post-op picture of the same patient with very good, the tissue has been very nicely taken over at the site of perforation and gives both the mechanical strength as well. It buys you time for any definitive procedure in the future. The conjunctival flaps are again one of the important methods for closing the perforations, preferably towards the peripheral sites. And you can mobilize the conjunctiva from the cornices, bring it forward, advance the conjunctiva towards the limbus and towards the corneal surface, and to cover the peripheral perforation, and they are sutured towards the side so that it gives the mechanical strength to that peripheral perforation, as well as it provides trophic factors and serves as a biologic patch in that area, and it facilitates corneal healing. One thing is that we must remember that these eyes are very, the inflamed eyes and the conjunctiva can be very friable, and it gets, cut thread or the buttonholing occurs in these friable conjunctiva. So we must always be very careful to handle these conjunctiva very gently. This is one of the video of the conjunctival advancement which we did for a peripheral perforation. And this was a case of herpes zoster ophthalmicus, which was complicated because of systemic steroids and secondary infection. We advanced and the conjunctiva was very friable. We advanced the conjunctiva towards the lesion and sutured it towards the sides, and it very nicely covered the perforation. And later on sutured towards both the side of the limbus. It gives the tectonic stability to the perforation and to the eye, and buys you time, as I said, for another procedure, elective procedure in a less inflamed eye at a later date. And this is the post-op picture of the same patient. We can see that the conjunctiva, which was advanced from the inferior fornix, covers the defect adequately. The final or the last procedure which we all take help of in larger size perforation, that is more than 5 millimeter, is the keratoplasty. It can range from the full thickness keratoplasty to lamellar procedures or the patch graft. That depends on the size, the depth of the perforation and the depth of the lesion, and also the cause or the etiology of the perforation. So one of the cases where you can see there was an extensive corneal thinning towards the periphery, a case of mycotic keratitis which was adequately managed with therapeutic PK in this case. So one of the Yes, the challenges which we come across in such cases is that trepanation of host tissue is difficult, owing to the absence of tissue rigidity because of perforation in such cases. Hence, one can use Fleringa ring to give support and to prevent scleral collapse during the surgery. And also, it is important to ensure a healthy donor-free bed of infection. At least 1 millimeter margin of healthy tissue should be ensured, so that the cheese wiring is not there and the sutures are adequately applied in such cases. It is also a good practice to mark your area of trepanation with the help of a trephine mark over the surface, which is to be excised. And also that we excise all the exudates, the membranes in the anterior chamber, and also the synechias present in the anterior chamber for a good apposition and a good formed anterior chamber at the end of the surgery. So this video of therapeutic keratoplasty, which was done for for a perforated mycotic keratitis here, I made a mark in the superficial part of the cornea, followed by the gentle dissection of the cornea, and you can see that the membranes which are present in the anterior chamber needs to be removed adequately, and at the end of the dissection it is also a good practice to do an irrigation with an antimicrobial agent, be it an antifungal or an antibacterial agent, followed by the appropriately sized graft which is sutured and placed with a 10-0 nylon. Another procedure which was attempted, DALC was attempted because we earlier thought that maybe a lamellar procedure can be done, but we ended up that the patient had perforation beneath the debris, so we proceeded with the full thickness grafting in this patient. Similarly, just like this last case, we do the complete dissection and suture the graft with the 10-0 ethelon sutures at the end of the graft. Yes, so that is the therapeutic procedure which we take help of for larger size perforations. The patch graft for small size graft, depending on the size, depending on the depth of the involvement, you can do the shaped grafting of the tissue can be done. A word about the non-surgical treatment. It is an adjunctive, a very important adjunctive treatment for all the surgical treatment. That is the lubricating agents to minimize the desiccation of the cornea and to minimize further keratolysis. Antimicrobial agents, of course. Anticollagenase like the tablet doxycycline 100 milligram twice a day is very important for preventing the for collagenase activity, and for these patients do very well with with the support of bandage contact lens and gluing of the patients. Again, the aqueous suppressants and bandage contact lens for small perforations are very helpful in closing such defects. So future direction, we are looking forward to bioengineered tissues, that is collagen, and also the plastic compressed gels in appropriate with. Of course, they are in experimental stages, but we may have them for clinical usage in near future. So take home message that we must be able to identify the cause of the lesion. Depending on the size, shape, and location of the lesion, we can use various techniques for closure of the perforation, as has been demonstrated in the previous slides. Large perforations are better managed with keratoplasty, and patch grafts for moderate lesions. Thank you very much for your patient hearing. Thank you.
Thank you so much. That was very nicely illustrated with the representative videos about a very important intervention to save the eye and can be done in any place. It's very important that this knowledge is available with corneal surgeons. Otherwise, the patient ends up with great difficulty.
So we have our next speaker, Dr. Rajesh Fogla, who's heading the ophthalmology department at Apollo Eye Clinics. And he's a very prolific cornea surgeon. We all are aware of his procedures and the lamellar keratoplasties, which Dr. Fogla is known about. So we welcome Dr. Fogla for his talk on emergencies associated with corneal transplantation, mission graft survival.
Thank you, Dr. Bhavana. Thank you for making me part of this course. And I think these are very relevant topics, which are very important in managing different corneal conditions. So I'll be talking about the corneal emergencies associated with corneal transplantation. I have no financial disclosure. If we look at the corneal transplantation, past 2 decades, we have witnessed a shift from full-thickness penetrating keratoplasty to lamellar keratoplasty. Looking at the statistics worldwide, we will see that now more and more people perform either anterior lamellar keratoplasty such as DALC or posterior lamellar keratoplasty such as DSEC or DMEC or ultra-thin DSEC. And if we look at the survival curves of these various graphs, we see that DALC, definitely the survival is longer because the host endothelium is preserved. And among the other cornea transplants, endothelial keratoplasty survival is better than regrafts and primary PK. So some of the common emergencies that you come across, one is the post-operatively, especially in the early post-op period, you can have a non-healing or a persistent epithelial defect. Management of this identification and management is important because if not, it can result in stromal melt and perforation and also predisposes to secondary infection. Now, why does this occur? It can occur if there is already a pre-existing limbal stem cell deficiency, especially in eyes with chronic allergic eye disease, or if there is reduced corneal sensation or some element of neurotrophy, if there is a scar resulting from herpetic infection and you do a corneal transplant, or if there is a lid malapposition, either an entropion or an ectropion, which prevents the resurfacing of the tear film, you can have this kind of a problem. Management, yes, from a simple application of bandage contact lens to doing punctal cautery or doing tarsorrhaphy combined with amniotic membrane transplantation. Depending on the severity and the type of problem that you see, you have to treat that, and you have to also address the underlying condition that results in this to improve the epithelial healing. And also you have to provide antibiotic cover to prevent any secondary infection. The other problem, especially with the lamellar grafts where you use air or gas tamponade, or especially with DALK, if you have had a perforation, sometimes you do a air fill to prevent a double anterior chamber. You can have this pupillary block where the air migrates to behind the iris, resulting in a raised intraocular pressure. If not managed, this can result in development of peripheral anterior synechiae, and it can also damage the optic nerve. So to prevent that, you can do a prophylactic inferior PI during the surgery or dilate the pupil post-op to avoid this scenario. And if not treated, it can also result in what is referred to as the Ehlers-Danlos syndrome, where you can have a fixed dilated pupil, and in a phakic eye, you can develop lens opacities as well. Once you see that, you have to, treat, you have to remove that air bubble and reform the anterior chamber. You can have raised IOP also resulting from the frequent use of topical steroids. So it's important that you see your patient in the first 1 or 2 weeks after surgery, because again, in a steroid responder, the pressures can go very high. You can have raised IOP also secondary to hemorrhage from the iris. So if you have blood in the AC, or if you have severe inflammation resulting from the synechial lysis that we commonly perform, you can have increased IOP, and this is also important to manage because it's detrimental to the health of the endothelium. Sutures, yes, not in the immediate post-op, but yes, in the early post-op or late post-op, sutures can break. In the early post-op, sutures can become loose, or they can develop these sterile infiltrates, or sometimes even you can get infective infiltrates. So important to address that, especially patients who have active lid margin disease like severe mebomitis post-operatively. The broken or loose sutures can bring in blood vessels, which can result in a graft rejection episode. And if it is associated with any debris or mucus accumulation, you can get secondary infection, melts. And so even the primary corneal surgeon may not be the person who's following up the patient. When they go to follow up and a general ophthalmologist sees that, I think it's important to get the sutures removed at the right time. If you leave them loose, or if they are present for a long time, it can affect the long-term outcome of the graft. And often we find that patient coming back with a rejection episode and a failed graft. Use of topical antibiotics should be started sometimes in broken sutures. If there are no infiltrates, you can step up the steroids as well, because the broken sutures can lead to inflammation, or it can result in the rejection episode, especially the endothelial rejection. Long-term leaving behind the sutures, even if the patient has good vision and not bothering the patient, you can get blood vessels coming into the cornea, and especially if lamellar grafts have been done, you can get blood vessels going into that interface, which is a easy access, and that can result in lipid keratopathy. And often we see patients only presenting to us when the lipid keratopathy starts involving the visual axis. We can treat them with steroids at that point of time. We can remove the offending sutures, but sometimes it leads to loss of the clarity of the graft. This is more common in patients with prior history of allergic eye disease, and you have to differentiate this from recurrence of herpetic stromal keratitis, where the clinical appearance may be quite similar, where you get a stromal haze and inflammation. Stromal rejection, again, can occur with anterior lamellar keratoplasty. If the predisposing factor is loose sutures, or if patient have previous history of active surface like chronic allergic eye disease. And as I mentioned that usually the patient will come back only if they have involvement of the visual axis and a drop in the vision. Often they don't produce symptoms as much as what you see with endothelial rejection. So any kind of redness in the eye persisting, or patient just, feeling a foreign body sensation should not be treated just by increasing the lubricants. A timely intervention by giving a little bit more steroids can effectively manage this stromal rejection. And if there are any loose sutures or broken sutures, they have to be removed, because without removing them, just giving them steroids is not really going to solve the problem. Endothelial rejection is a much more emergency situation, because the earlier you treat, the better the outcome. Patients will typically have the redness, sensitivity to light, visual disturbance, and pain. So this is something that we explain to every patient undergoing a corneal transplant, that if you have any of these symptoms, definitely report to your local ophthalmologist, or at least come back to the primary operating surgeons. Some of these symptoms are usually milder, especially if you have undergone a DSEC or a DMEC, where the patient may have like a subclinical features, and only when you examine on slit lamp, you can see the keratic precipitates or a mild anterior chamber reaction. And the keratic precipitates are limited to the graft, and you don't see them on the host side. So stepping up the steroids and sometimes giving IV methylprednisolone can help reverse the rejection and save the graft from failing completely. It's also important to differentiate this from viral endotheliitis as well, where the clinical feature may look similar, but you will see the keratic precipitates both not only limited to the corneal graft, but you will see them beyond the graft as well. And if you take a proper history, maybe in the prior records, you will see that the patient had therapy with antivirals at some point of time. And besides treating the inflammation, when you step up steroids, it's also important to monitor the intraocular pressure. You can give oral IOP lowering agents and use topical agents as well. And following that, it's important to keep the patient on a slightly higher frequency of using topical steroids, especially because now they have a reduced pool of endothelial cells, and you would not want to have a repeat endothelial rejection. And I find topical tacrolimus also adding to the regimen really helps, and you can, kind of gives you a dual advantage besides using just steroids alone. This is a nice chart depicting all the rejections that you see, the epithelial, subepithelial rejection, and you have your stromal and the endothelial rejection. The epithelial, subepithelial are quite easier to treat. They don't affect the overall health of the corneal graft. But yes, sometimes these are misdiagnosed as adenoviral or pneumolar keratitis, and although the treatment remains the same, but I think it's important to differentiate from other conditions like microsporidial or herpetic or even a pseudodendrite. Infective keratitis, yes, you can get typically when we do a corneal graft, and unless you stain, you can miss this. You can have a patient coming back where the cornea looks relatively okay. There's a faint haziness on the cornea, and if you put a stain, you will realize that there is a recurrence of the herpetic keratitis, because if the primary condition had a corneal scar with vascularization, you go ahead, do a penetrating keratoplasty, and now the patient is on topical steroids, and you find that in the early post-op period, without any coverage of oral antivirals, you can get this recurrence, and this has to be identified and treated, because if you don't do that, the defect remains for a long period of time. You can have stromal involvement, stromal melt, and ultimately you can lose the graft. You treat with topical and systemic antivirals. I usually avoid giving topical antivirals for beyond 2 weeks duration. Oral antiviral prophylaxis is carried on for as long as at least for a year if the patient can tolerate. And if there is any contraindication for systemic antivirals, you can use topical ganciclovir as well. If you don't remove sutures on time, you can definitely get infection. Broken sutures can lead to infections. But remember that, especially if you're doing a corneal graft, you can get infection in the early postoperative period from the donor graft itself. And if you get it in the first 1 week, and if it is very quick with a short history, usually bacterial, And if you get a delayed kind of onset, like after doing a DSEC or a DMEC, and you see an interface opacity, that's commonly fungal, and people have found that Candida to be a common culprit for the same. But I think early suspicion is the key factor here. And it's, you get your tissue from the eye bank, you look at the notes given by the eye bank, but if you don't evaluate the tissue yourself, sometimes you can be in a problem, because remember, the eye bank technician has looked at the graft and they have prepared the report and then they put it in the fridge. But once it comes to you, there are temperature variations. Always look for any change in the color of the medium. If you know that this is what the orange color of the solution that you have, if it has turned dark orange or if it has turned violet, you know that there is change in the pH and you may not be using the graft at that point of time. Increased turbidity of the medium itself also indicates that there is something wrong. So always keep a suspicion for that. And if you've done a lamellar graft and you see an infiltrate in the interface, sometimes topical therapy may not be able to access that interface very well. I feel that early removal of the donor lenticule and then treating the infection and then repeating the surgery at a later date seems to be a better option. If it is very fulminant, then you can even do an early therapeutic keratoplasty rather than waiting for the infection to spread. You can also get stromal melt from any of the earlier indications that we said, like a non-healing epithelial defect, loose sutures, or the primary condition for which the patient was being treated because of underlying systemic disease. So it's important that you suppress the inflammation, restore the integrity first, get the surface to heal, treat the systemic condition, then you can go back and address the corneal graft. Like this is a patient underwent a DALC, had a melt, and then we treated, and then finally underwent a repeat DALC and sorted out. Finally, you can have trauma resulting in wound dehiscence. This is again an emergency where if you manage the condition properly, it often results in the loss of the crystalline lens and the vitreous prolapse. We used to think that DALC gives you a stronger wound, but that's not the case. This is a patient who had undergone a DALC, got hit in the eye, and you had this kind of a clinical picture, was managed by the local corneal surgeon by suturing, and later on we did a secondary IOL implantation and the graft still remained very clear. So I think it depends on the original amount of damage and how the patient was managed primarily in terms of the outcome of this kind of clinical scenario. So basically, to optimize graft survival, I think appropriate selection of the donor graft, meticulous intraoperative technique, use the appropriate prophylactic and therapeutic agents, especially immunosuppressive medications and antibiotics as and when necessary. The regular and close follow-up is very important. It's important to spend time with the patient, explaining to them all the possible things that can happen and why they need to respond very immediately, why they should have extra bottles of medication with them, because often you find patients say that, oh, I ran out of medication and this was not available, so I didn't apply those medications. And timely intervention for any of these complications. Thank you. Thank you for a patient hearing.
Thank you, sir, for a very informative lecture on management of various corneal complications after keratoplasty. And it is the key to manage such cases is adequate identification of the condition and the timely and appropriate management, whether it is surgical or medical, to be instated to salvage the visual acuity in such patients. I invite the next speaker, Professor M. Vanati, who is the professor cornea refractive surgery at Dr. R.P. Center for Ophthalmic Sciences, AIIMS, New Delhi. And she will be speaking on emergencies associated with advanced corneal ectasias. This is a very pertinent topic, and we frequently come across such conditions which need appropriate management to salvage visual acuity in such patients. Meantime, Madam is preparing for her presentation. Okay.
Thank you, Doctor. Thank you, Dr. Bhavana, for having me in this nice session here. So in the next few minutes, I will be taking you through emergencies associated with corneal ectasia. Have no financial interest in the mention of any of the products during the course of my talk here. So just to summarize what all could be the particular concerns when you're dealing with corneal ectasias. One is it can arise which could be because of collagen cross-linking related. Other could be because of contact lens wear. The ocular allergy which could be associated with many ectasias is another concern which can cause emergencies. Corneal hydrops is a particular emergency with any type of ectasias here. Then hydrops related problems and concerns and complications themselves can land up patients in emergency situations here. Keratoplasty in corneal ectasias. I think Dr. Fogler has already covered widely all those aspects of emergencies related to keratoplasty in ectasias here. And finally, but not the least here, it's trauma. So these are the various aspects one has to look at when you're looking at emergency situations in corneal ectasia patients here. So collagen cross-linking now, whatever be the protocol you do follow for your patients, depending upon the particular logistics of the ectatic characteristics here. The main complications, the main concerns which can arise when you're taking your patients through collagen cross-linking is some amount of corneal haze, presence of sterile infiltrates which can occur in the postoperative, immediate postoperative period, infectious keratitis itself here. So infection is one. Always do look at these procedures as invasive procedures, and you would not want to have an infective keratitis on your hands when you're doing a collagen cross-linking here. There could be herpetic lesions which can get reactivated in patients when you're taking them for collagen cross-linking. Corneal edema in certain cases, and when you're not probably following the protocols on the depth involvement or the corneal thickness. Damaged or inadvertent endothelial cell loss could be another problem with these patients here. And again, continued progression. Of course, that would not be an emergency here. So do remember, when the procedure is being done, it needs to be done as with all aspects or all protocols of a sterile procedure. We commonly do advocate take a conjunctival swab in your patients preoperatively so that you're taking care that the conjunctival flora is optimal and is not predisposed to any infections in these patients here. Preoperative antibiotic if you're taking these patients on here, and collagen cross-linking being done in a sterile procedure. Always do take care that the lids and the lid margins and the eyelashes are properly cleaned and going through your aseptic protocol for all your procedures here to prevent postoperative problems in these patients as well here. There are several types of enhanced protocols for dealing with thin corneas here. And again, be it whether you're using a contact lens assisted, a lenticule assisted, or the various custom protocols here. Again, these can be predisposed to infections during your procedure. So do take care that these are all not going to land up with problems in your patients. Important is to differentiate an immune infiltrate from a sterile infiltrate in your patients here. So immune infiltrates, the patients are not so symptomatic. They tend to be smaller in size here, usually peripheral, and you'll need to identify because you need to give steroids for this to go away. Vis-a-vis an infective infiltrate with a patient who's going to be more symptomatic, a larger area of involvement, and you will have to follow the protocols of management of an infective keratitis in dealing with these patients here. So that's going to be the difference when you are looking at managing postoperative infiltrates in collagen cross-linking for corneal ectasias here. Next, we'll move on to hydrops itself here. So hydrops is a unique concern which does occur on rupture of your Descemet's membrane here and can occur in keratoconus, can occur in pellucid marginal degenerations as well. So management dictums is, as all we know, the medical management is what we put the patients on is hypertonic saline and steroids, anti-glaucoma if required, and do cover them with antibiotics here because hydrops can get complicated with infections as well. Perforations have also reported to occur in cases of long-standing chronic hydrops patients here. Patients typically present with photophobia, watering, pain, and redness here. Corneal edema and haziness is all there in advanced cases, but you might not be able to see them when the patients are presenting early with just with a mild haze. Vision still might be good enough for these patients here. Those with chronic or severe hydrops patients, you would want to go in for an intracameral air or gas management in these patients here. Again, consider a very simple procedure. But do remember that if you are using gas, you will have to use a non-expansile proportion. It's 14% of C3F8 or 20% of SF6 here. And this when given in the early periods, helps in rapid resolution of your corneal edema and clearing of the cornea and better visual rehabilitation of these patients. But the word of caution there is when you're using air or gas in these patients, you can land up with a pupillary block glaucoma or malignant glaucoma in these patients. So that is something, and I have particularly burnt my fingers with one young patient here. So you always look at it with particular caution when you're looking at bubbling your eye drops patients in cases of chronic cases. Infection, perforation, malignant glaucomas are particular concerns. We do not see them very frequently, but if they do occur, they are going to be bad emergencies which you would not want to manage in your cases here. The mechanisms for corneal eye drops have been elaborated well enough here. The occurrence of microbial keratitis and its poor prognosis has also been elaborated in most cases here. And you could use the AIOCT to look at the progress of your patients once you are bubbling them for management in cases of eye drops here. Again, the word of caution is look for pupillary block glaucoma. Be careful, and then whoever is assisting you, if your scrub nurse is preparing your gas concentrations, ensure that the concentrations are going to be non-expansile here, so you do not want to have a pupillary block or a malignant glaucoma in your hands here. Again, evidence in literature also points out even when you've used non-expansile combinations of gas, there have been reported incidents of raise in intraocular pressures in about 6 to 18% of cases when you use them for RD surgery. The same can apply to your eye drops patients as well. So this is one particular patient who developed malignant glaucoma following intracameral gas injection in one of my patients here, and needed a lensectomy here for resolving the emergency situation. And then subsequently on went in, was able to rehabilitate with a secondary IOL and a graft for that particular patient. This is just a word of note for all of you if you want to look at how you need to mix your gases when you're making your 20% SF6 or a 14% C3F8, a rough guide, and which if you would follow, you would not land up with problems because of improper gas dilutions here. I think this is one fantastic latest paper here which does talk about a modified technique of using compression sutures for large and non-resolving eye drops here. So where you do use a modified technique of placing your compression sutures here and a simple air injection and a contact lens here, this does away with many of the other concerns which I just narrated to you about here. So this is an effective method and has been shown to work well in patients with large ruptures of Descemet's membrane. They are chronic here and does away with the need of other complications because of and logistics involved with gas injections as well. Next, we move on to concerns related to contact lens wear in ectasias here. So we do have a wide variety of contact lenses, starting from simple rigid gas permeable to modified RGP lenses to your rose-K lenses, and a wide armamentarium of semi-scleral and scleral contact lenses. But please do remember, for most of us who are fitting contact lenses in our ectasia patients, you do not want to land your patients on problems because poor fitting themselves can lead to a lot of corneal problems in terms of corneal staining, in terms of conjunctival hyperemia, in terms of increasing vascularization of the peripheral cornea, in terms of precipitating infection in these corneas here. So that's something you'll need to know on your logistics depending upon the type of lens you're fitting, particularly if you're using many scleral lenses, a very adequate teaching schedule for your patients here, and the patients need to be aware of the sterile way of removing and putting the lenses on and how frequently it has to be done depending upon the debris collection in the tear vault here. So these are important aspects which one has to reiterate to your patients who are on contact lens wear when you're managing ectasia cases. Another particular problem in corneal ectasias, particularly patients of keratoglobus, is trivial trauma or landing up with simultaneous or landing up with perforations without any predisposing trauma, evidence of trauma in such cases. This is one such case of keratoconus which is still following up with me right from when this patient was a child here, and especially if you have the association of brittle cornea syndrome here. This is a congenital anomaly, and this looks very similar to an associated Ehlers-Danlos here. But these patients do come to you with recurrent corneal perforations even without without evidence of trauma or very trivial trauma with just touch of a finger here. And repairing these cases becomes particularly difficult because you will have cheese wiring of the cornea when you're passing sutures on here, and you will have to augment it with use of glue and with bandage contact lenses when you're managing these cases. So these are particular difficulties when you're managing corneal trauma in brittle cornea syndromes here. Again, the most important aspect is management of emergencies arising due to associated ocular allergy in corneal ectasias here. So one is, again, the corneal haze is very severe in cases of chronic BKC, chronic atopic keratoconjunctivitis associated with ectasias. The symptoms and the signs tend to be more severe in these cases here. More corneal haze here, more conjunctival problems here, limbal problems in these patients here. And of course, the occurrence of shield ulcer is one which you probably need to take on and manage aggressively in these patients. I think I won't run you through these because Dr. Fogla has already talked to you about, but then management of rejections in DALK is very important, because when these are picked up early, you would probably be able to reverse the rejections here and restore the visual rehabilitation which you have been able to achieve in your patients. Rapid suture loosening, especially in patients associated with ocular allergy, where the surface has a higher amount or a higher quotient of inflammatory mediators, is a particular concern, and the problems arising due to those need to be managed. I think I'll stop here and thank you for your patient hearing.
So much, Professor Vanathy, for covering the topic extensively with very nice illustrative cases. It's a very important area for corneal practice. So we have one more presentation, Dr. Amit, but he's held up in another session. So we can proceed with the keynote address. Professor Bhavana would like to introduce.
So we have one more presentation of this session which is left. That is Professor Amit Gupta would take the principles and techniques of managing corneal lacerations. He is presently having another presentation in some other hall. He would be joining us shortly. In the meantime, we can have the keynote speaker of this session, Dr. Mohammad Saad, who would be taking the lecture on future of fungal keratitis.
Welcome everybody, and thanks for the invitation for this prestigious meeting. I'd like to talk about the future of fungal keratitis management. I have no financial interest. We all know that the problems of fungal keratitis ranging from resistance, lytic activity by the enzymes or by the endotoxins, penetration, perforation, and the delay in the diagnosis, and sometimes improper diagnosis, and all this dilemma we all met in management and in dealing with patients with fungal keratitis. Recently, there are some new advances in investigations, like the in vivo confocal microscopy, polymerase chain reactions, and we'll talk about the idea of each of them. The second item is the recent medical treatment. We have the liposomes. We will talk about the mechanism and the advantage of liposome use, the nanotechnology, ozone therapy, and a new groups of drugs. The last item in the recent advances is the surgery, like the intrastromal injection, corneal cross-linking, and keratoplasty. We'll start with the investigations. Confocal microscopy has been advocated to manage this patient for diagnosis, for very early diagnosis, rapid and with a very good resolution, about 1 micron. So it's more effective than the usual investigations of culture and sensitivity. Also, the polymerase chain reaction, either the traditional type or the multiplex type, and both of them has an advantage of very rapid diagnosis within few hours, about 4 to 8 hours. And this is give very high sensitivity and so it is very accurate and very rapid for diagnosis. Also, we have some new drugs like voriconazole and busaconazole, which are very effective, less toxic, better penetration, and better patient compliance. Now we will talk about the liposomes. As we all know that liposomes are artificial vesicles with concentric lipid bilayers and separated by water. The vesicular drug system characteristically is very effective as it has a prolonged and controlled action. It prevents the metabolism by the enzymes, biodegradable, non-toxic, and very better drug absorption. And this is our advantage. These are some advantages of the liposomes. We have this clinical trial on animal rabbit eyes, about 40 eyes, induced with induced bilateral candida keratitis. We have these two comparative studies to compare the effect of the liposomes loaded with the fluconazole in comparison to the conventional fluconazole with the usual treatment. And the success rate was higher, about 86% in the group of liposome instead of 50% on the conventional treatment. These are some examples of the rabbit eyes before and after application of the liposomes, and was published in Acta Ophthalmologica. We have another study on human eye. About 11 eyes with candida keratitis was treated with fluconazole-loaded liposomes. And these are the results. And these are some photography of these patients before and after the use of the liposomes. So to conclude that liposome used has a very high success rate, prolonged duration of action, higher corneal penetration, better eye tolerability, and was free of side effects. This was published in Corneal. Another item is intrastromal and intracameral injection of antifungal drugs. We have many antifungal like amphotericin, fluconazole, voriconazole with different concentrations, and we can use them. The usual way to inject the antifungal, as we know, using a small gauge needle, 30 gauge, with bevel down, where you can apply more than 4 or 5 applications around the ulcer. And these are some examples of the intrastromal injection and the pre-injection and the improvement after the injection. Also, intracameral amphotericin may be used in some cases, especially in deep mycosis or with patients with endothelial plaques or presence of dense hypopyon. These patients will get improved dramatically with intracameral injection of amphotericin. As regards the corneal cross-linking, as we know, there is no known mechanism of action, but it may release some reactive oxygen, may produce oxidation of pathogenic DNA, damage of cell walls, increase corneal stiffness, killing of inflammatory cells and immune cells. These are some advantages of corneal cross-linking. The use of corneal cross-linking for infective keratitis is not new, but started to improve. The overall success rate in our series was about 87% in comparison to 70% for conventional treatment. And with the shorter revitalization and earlier recovery. There is no recurrence or perforation with patients with corneal cross-linking. You have to know that the better time to introduce or use the corneal cross-linking should be earlier as possible before the infection get very deep in the cornea. During the affection of the anterior 1/3 of the cornea, because and we can use anterior segment OCT, of course, to detect the depth of the infection, because deeper infection may flare with corneal cross-linking. The trial was done, and these are some results, and the time of healing has much more better in patients with cross-linking than the usual conventional treatment. These are some patients pre and post-use of corneal cross-linking. Another group, third group. And these are the anterior segment OCT showing the reduction of the thickness after improvement with the use of corneal cross-linking. So to summarize, corneal cross-linking may be adjunctive and useful treatment for fungal keratitis. It is more useful in early cases. It prevents corneal melting and will deal with the resistant organisms, and was published in this. The last item is use of ozone in fungal keratitis. Recently, ozone have been tried, and we have some experience with it. As we all know that ozone is a very effective germicidal, bactericidal, antiviral, antifungal agent. It has the strongest oxidative effect. It reactivates the antioxidant system of the body and has anti-inflammatory effect. All these advantages may make the ozone as a suitable treatment for fungal keratitis, and that allows also tissue healing. Ozone may be used in gaseous tests, not suitable for clinical use. We use it in saline actually because this is the available tool in our country, but some countries had available ozonated oils we use as an eye drops, but not in Egypt. These ozone have a short half-life. This is the only disadvantage. About 2 hours. If you have to repeat it twice or 2 to 3 times per week, and so we will get benefit from it. And this is the way how to prepare the ozone for these patients with the ozone generator, which is very cheap instrument, with the using of the ordinary tear substitutes available in the market, and ozonate it or apply ozone to it. And we have this clinical trial with comparison between 2 groups, a group using ozonated saline as for treatment in addition to the antibiotic or antifungal in comparison to the usual treatment. The success rate was much better in cases of ozone with a shorter duration of healing and better response. And these are the photography of some patients with ozone pre and after application of more than 1 session for ozone. These are another patient. So to conclude, ozone may be an alternative and adjunctive treatment for refractory cases of fungal keratitis. It has an anti-inflammatory and germicidal activity. In addition, it promotes tissue repair. The last item is the use of therapeutic keratoplasty versus DALC. We will have no lot of time to talk, and I think the professor had been talk about it. But we have to conclude that we have to get small cases, small ulcers, less than 7 millimeter. We have to complete the pathology completely with a safety margin, and early interference is a must. Also, we almost use handheld defines. We control bleeding. We use viscoelastic. Use antimicrobial. Better to deal with the patient fatigue. These are some instructions. Of course, stop steroid post-operative for a few days and control the intraocular pressure. And these are some advantages of some uses for therapeutic keratoplasty. These are some patients pre and post therapeutic keratoplasty. So take-home message is fungal keratitis is a sight-threatening condition. Decision-making in proper time may be save the infected eyes. Non-traditional lines might also be add benefit to these miserable cases and may change our future strategies. Surgical intervention with special precautions may be the only choice to save these eyes. Thank you.
Thank you, Dr. Muhammad Saad, for this wonderful lecture on recent advances in management of mycotic keratitis. Now we invite Professor Amit Gupta, who is Professor of Ophthalmology at Advanced Eye Center, PGI Chandigarh, for his talk on principles and techniques of managing corneal lacerations. It is a very important topic, not only for the trainees, but also for all practicing ophthalmologists. We very frequently come across such cases. And all the more important is that such, the corneal lacerations and penetrating injuries are seen more frequently in children and adolescents. So it becomes very important to manage them appropriately and timely. And we invite Dr. Gupta for this presentation.
Thank you, Dr. Bhavana. Thank you for making me a part of this very important and interesting instruction course. And I'll be talking about principles and practical aspects of repairing corneal lacerations. Now, we know that corneal laceration is a full or partial thickness wound in the cornea caused by a sharp objects. It's an ophthalmic emergency. It is more in children and breadwinners of the family. So it's so important that we try to reduce them. It is many times preventable. There are medical legal issues involved, and many times they are challenging because they are associated with so many other scenarios in the eye. So step one is the assessment of the patient. We need to have the mode of the injury, the time since the injury, the systemic status and external examination of the face and lids, and also the baseline visual acuity, which has been correlated to a better outcome. The better the visual acuity at presentation, the better is the outcome of the patient. Also, the pupil examination, and the patient should be given a rigid protective shield, and we should give antiemetics, analgesics in apprehensive patients to avoid positive pressure or to avoid lid squeezing and vomiting in these patients. These are small but very, very important things when it comes to ensuring good outcomes in these patients. Also, rule out any foreign body either by a gentle ultrasound or by the X-ray, which should be a rule in these patients, especially from a medical legal point of view. Now, something which we ignore is the tetanus prophylaxis. Now, what is the protocol for tetanus prophylaxis is that if the patient is fully immunized, has more than 3 TT doses, then if the wound is clean or minor, then we should give the TT if the last dose was more than 10 years old. If it's a dirty, large wound, we should give the tetanus toxoid if the last dose was more than 5 years of age. Of course, non-vaccinated need a tetanus toxoid every time. So, the second step is, the third step is to prevent or treat the infection in this patient. Of course, we do, as a rule, give systemic antibiotics to these patients. And fluoroquinolones are pretty good at this because they have such a broad spectrum. We should give clindamycin in case there's an intraocular foreign body which is vegetative in nature. And we can also give a combination of vancomycin and ceftazidime as a broad spectrum antibiotic. Topical preservative-free drops like moxifloxacin can be given, but by and large, intraocular toxicity is an issue, and we should minimize the drops. And also we should send cultures. The important thing is when you see these contaminated wounds, send cultures of these patients so that, at least you get something at the end of 24 to 48 hours, which gives us a clue to treat the infection. How to classify and prognosticate these patients? Now, the BETS is the most famous classification. This is the Birmingham Eye Trauma Terminology System. And so it divides the groups into closed and open groups. So these are two broad groups. And when it looks at closed group, it is either a contusion, so there's an injury without a rupture of the globe, or there's a lamellar laceration. An open globe is a rupture or a laceration. So when we are talking about lacerations, they may be penetrating where the foreign body remains inside the eye. There's just an entry wound. And in perforating, the foreign body has entered and exited the eye. And also there's an intraocular foreign body in these patients. Now, there was an article, and there's some other comments and articles that it misses out on certain situations. Almost 22% of the trauma cannot be classified in this. Just enough that that there is an addition to the beds. For example, a foreign body which is on the periocular tissue or lodged just in one of the coats of the eye. So many situations are there. But by and large, if you keep beds in mind, it gets you to a good place when you're treating corneal lacerations. Then we need to classify the laceration where it is. So it is divided into 3 zones, the eye. One is at the limbus, and one is 5 millimeters away from the limbus, and the other one is basically posterior to the anterior 5 millimeters of the sclera. So if you look at this, so this is extremely important, and we have other things. So there's a type A, B, C, D, E, and there's a grade according to the vision 1, 2, 3, 4, 5, and there is a zone 1, 2, and 3. So you might say there's a grade 3, zone 2, or zone 1 and 2 injury, and it's a type C or something. So we should classify it like that. So how to prognosticate these patients? There is something known as an ocular trauma score. So patient starts off in a very ideal case with 100, which is a visual acuity of more than 20/40. So this is the kind of importance which has been given to the presenting visual acuity of these patients. And there's a minus for each point. So there's a minus 23 for globe rupture. So we have a sum of all the raw points, and that it helps us to prognosticate the patient. For example, if the raw sum score is 0 to 44, this is only a 1% chance that after 6 months this patient is going to be seeing 40 or better. And if there's a high score of 92 or 100, almost a 92% chance that patient is going to be more than 20/40. So just an algorithm to manage. So once we have a patient of corneal laceration, there may be a partial thickness of laceration. So in that case, patching BCL might work. In case there's a very ragged kind of a thing, we might put sutures. And in case of simple full thickness injuries, less than 2 millimeters or more than 2 millimeters, we should note. So less than 2 millimeters self-sealing, we can be conservative. Now this is a very, very tricky situation, because every time we see these patients, should we suture, should we not suture? As a rule, if there's any sign of infection, hypopion, something like that, we do try to pass a suture or something just by a no-touch technique and seal it in any case. In case there's more than 2 millimeters, it's non-self-sealing, stellate, tissue loss is there, we should go ahead with surgery or some kind of other adjuncts like some glue, and or going for a definitive surgery. How much time do I have, madam? I know we are running out of time. I'll wind up whenever you, because it's a long topic. So I'll just try to just quickly go through and wind up now. Okay, so we have to, many of these patients will require a second procedure. So our primary job is to do a nice clean repair, restore the integrity of the globe, and just leave it at that. And there are several surgical principles when it comes to handling these patients. Especially, we should look for these occult perforations. So if case there's a rupture, a globe rupture or an injury, I'm sorry, this is not. So we should just try to isolate the muscle, lift it up with the help of muscle hooks without putting pressure on the globe, and just try to see what is the extent of the injury. I'll just, I think, sum up, because it's a long topic and we are just short of time. So another important thing is when we are putting the eye speculum, how we prepare the patient for surgery. We should preferably do under general anesthesia, or we can use a subtenon or parabulbar anesthesia. I think so. That is very, very important when it comes to managing these patients. So I'm just going to just go to the last slide. So this was a very interesting patient where the surgeon, thinking that it was vitreous, had cut the entire retina. And we had a big problem. This was referred to us, and this was what was left of the retina. And of course, there are suturing techniques, how you suture these patients, and the most famous of them is the Rousseau-Hayes technique, where you apply shorter, shallower sutures in the center. And so, with due care, we can ensure that we reach the surgical goal of having a watertight wound closure, restoration of normal anatomical relationships, restoration of the optical visual function, and prevention of possible future complications in these patients. Thank you very much.
Thank you, sir, for a very informative lecture on management of corneal lacerations. And that was the last presentation from this instruction course, that is Comprehensive Management of Corneal Emergencies. Thank you very much. I thank all the co-instructors who have been here today to take this instruction course forward, and very informative lectures. Thank you all for being here. Thank you, the audience, for being here. And I request all the co-instructors and the keynote speaker, Dr. Mohammad Saad, for a quick photograph, please. Thank you.